and that's through a plant-based diet. I don't necessarily mean vegetarian exclusively, but certainly a plant-full diet. This first data point was a meta-analysis of 83 studies, and it found that adherence to a Mediterranean-style diet resulted in about a 6% reduction in breast cancer. And, 6% is marginally clinically significant, but it is certainly moving the needle in the right direction. When you compare adherence to a Mediterranean diet and breast cancer mortality, you see a more significantly clinically impactful effect, so that there's a 57% reduced risk of breast cancer specific mortality in those individuals most adherent to a Mediterranean-style diet. Again, that effect is thought to be due to the high inclusion, high amounts of fiber and vegetables and fruits. There was an important randomized control trial called the Predamed Trial, which found that the Mediterranean diet supplemented with extra virgin olive oil resulted in a 41% reduced risk and 68% reduced risk and a 41% reduced risk when that Mediterranean diet was supplemented with nuts. So that the essential fatty acid component of the Mediterranean diet appears to have a very important impact on the risk reduction. And then finally, in a systematic review meta-analysis of cross-sectional and cohort studies, vegetarian and vegan diets, again, diets that are plant-full, are associated with about an 8% reduction in total cancer risk, although there was no association seen with all-cause or cancer-specific mortality, but again, moving the needle in the right direction. Now, in terms of looking at the Mediterranean diet on a continuum with the Western diet, those being the end, positioning those at each end of the continuum, when you compare those diets, the more adherent somebody is to a Western dietary pattern, which would be a highly processed foods, high meat-based diet, there's a 46% increased risk of breast cancer compared to, on the other side, a Mediterranean diet pattern has a 44% reduced risk. So that, I think, is a more helpful way to understand the impact of diet in a comparative sense. And if we look at that Western diet, one of the big problems in a Western diet is the content of ultra-processed food. For every 10% increase in the proportion of ultra-processed foods, which are essentially packaged foods with ingredients that we can't pronounce, there's a 12% increase in the risk of cancer overall and an 11% increase in the risk of breast cancer. So this is a very important finding. I was waiting a long time for this study, and it finally came out in 2018, so it helps us to really nail the coffin on the Western American diet. If we look at some of the components of the diet and how the diet might be influencing breast cancer risk, one of the things specific to breast cancer, of course, is estrogen. Although not all breast cancer is estrogen receptor positive, the majority of breast cancers are. And in fact, when we consume a diet that's high in fat, we have more circulating estrogen. So if we restrict our fat to about 10 to 12% of our caloric intake, we see a reduction in serum estradiol levels by about 7% in premenopausal women and about 23% in postmenopausal women. Also, fiber is a really important component in this way. Fiber, as we know, binds to unconjugated estrogens in the digestive tract and prevents them from being reabsorbed and recirculated. So when we look at the highest level of fiber intake compared to the lowest level of fiber intake, we see about a 17 to 22% decrease in circulating estrogen. That may underscore part of, or may contribute to part of the reason that a Mediterranean style high vegetable type of diet is associated with lower risk. And this is yet more data points on fiber specifically. This first is a systematic review and meta-analysis of prospective studies looking at fiber intake and breast cancer risk. And essentially every 10 grams per day of dietary fiber gives us about a 5% reduction in breast cancer risk. And what's interesting about this is that this risk reduction is most seen when the diet is naturally high in fiber, over 25 grams a day. That's hard to get for a lot of individuals. And even more importantly, the risk reduction appears to be very specific to soluble fiber, not insoluble fiber, which is the majority of fiber in a vegetarian diet. So soluble fiber we have to get from seeds, from legumes, from oat and bran. Those are the primary sources of soluble fiber in the diet, and that's where we really start to see a reduction in breast cancer risk. And then in the second data point, this is another systematic review and meta-analysis that was published in 2020, again of prospective studies. And in this study, total fiber consumption across the board was associated with an 8% lower risk of breast cancer for both pre- and postmenopausal breast cancer. And again, soluble fiber was found to be the primary reason for that risk reduction. Now, there was a very important trial that was published originally back in 2017, which at the time was the first multi-center trial that was prospective, looking at diet and breast cancer risk. And in this study, they compared standard diet to a diet that had more fruits and vegetables and restricted fat to no more than 20% of the total caloric intake. And they followed these women for 16 years on average. And what they found in this diet was that although the death rate after breast cancer in general did go down in those who were in the intervention group, the death rate as a result of breast cancer on the left here did not reduce in a statistically significant way. So this big study concluded, doesn't really matter what you eat, diet doesn't affect breast cancer risk. And by the way, the death after breast cancer was probably mostly due to cardiovascular disease, at least that's what we thought at the time. Fortunately, there was a follow-up study that was published in 2020, same group of women followed now for 19 years on average, so an additional follow-up time period, and now, new to this study, we see a statistically significant 21% reduction in breast cancer specific mortality. So this translates to an absolute risk reduction of about 1 fewer deaths as a result of breast cancer for every 10,000 women following this pattern. That may not seem very clinically significant, but if you look at this from a public health perspective, and you just look at U.S. data, that would mean that among the 160 million adult females approximately in the U.S., there would be 16,000 fewer deaths from breast cancer, and that's pretty significant. So I think, again, this indicates that this vegetable-rich diet does have an impact on cancer, and specifically breast cancer. When we look at the Nurses' Health Study, again, another study published in 2020, we see that there was a reduction in all-cause, although not breast cancer-specific mortality from total fruit and vegetable intake. Again, we see that with vegetable intake. But then when they drilled down to certain foods, they found that 2 servings at least a week of blueberries was associated with a 25% reduction in breast cancer-specific mortality. That post-diagnostic green leafy vegetable intake was associated with reduced all-cause mortality. They did not see a reduction in breast cancer-specific mortality. Cruciferous vegetables, again, associated with reduced all-cause mortality, not necessarily breast cancer-specific mortality. And conversely, higher fruit juice consumption was associated with higher breast cancer-specific and all-cause mortality. So yet another, set of data points that perhaps are a bit confusing, but when you step back so far just in the data I've presented and look at the degree of risk reduction, it's not surprising to me that we would see some of these studies showing benefit in terms of risk reduction, other studies not showing benefit. It really depends a lot on the quantity of intake, the duration of the trial, the type of breast cancer we're looking at, etc. But I think, again, the body of data shows a trend towards improved or I should say reduced risk of both breast cancer incidence and mortality in high fruit vegetable intake. Now, a question that I get a lot is, what about fat? There was a lot of information given that, especially in the 2000s, 1990s, that high fat was associated with increased risk of breast cancer. But in fact, high fat intake is actually associated with a slightly lower lethal breast cancer risk. And that's probably because fat includes a lot of different kinds of fat. When you look at the specific types of fat, what we see is that animal fat, specifically in premenopausal women, not in postmenopausal women, but in premenopausal women, animal fat, and even more specifically red meat animal fat, is associated with increased risk of lethal breast cancer. So that suggests that red meat is perhaps problematic and that the rest is not strong enough of an influence to really show up in these trials. Now, related to diet is weight, and of course there are lots of other things that go into weight, but it's important to talk about weight and cancer risk. Increased weight, obesity, is associated with increased risk of cancer. For every 5 kilograms of increase in adult weight, the risk of various cancers goes up, and you can see breast cancer is on the list. Kidney cancer is very strongly associated with increased weight. The World Cancer Research Fund has a list of 13 or so cancers that have been fairly, they would argue, definitively associated with excess weight. Now, in terms of breast cancer, when you're looking at premenopausal estrogen receptor breast cancer, being overweight will increase the risk of dying from a breast cancer diagnosis by about 34%. If you're looking at postmenopausal women who gain weight after menopause, they are at a 35% increased risk of breast cancer. And that's in sort of opposition to some compelling data that suggests that premenopausal weight gain, especially between the ages of about 25 and 34, is actually inversely associated with breast cancer risk, and that weight gain between 35 and 44 is not associated with risk. So that sounds a little bit confusing. Some of the rationale behind that, or the understanding behind that, is that weight gain in early adulthood is associated with decreased breast density, and we know now that breast density, when it's increased, that's a very significant risk factor for breast cancer. It's also true that young women who have excess weight have lower estrogen levels, generally speaking. Heavier premenopausal women have better clearance of their estrogen, and they have lower breast cell proliferation rates than leaner premenopausal women. And, the interplay between estrogen, weight is there, but really we need to look at insulin too. There are certain women who have excess weight who are also insulin resistant. And with insulin resistance comes higher levels of insulin, and insulin is a very pro-tumorigenic hormone. It contributes to a lot of the components of tumor formation. And when we eat a diet that's high in saturated fats, especially high in fructose, high in sucrose, we will accumulate adipocytes, but will enlarge our adipocytes. And when the adipocytes get enlarged, they send out inflammatory cytokine signaling, which attract macrophages. The macrophages become activated or polarized into their M1 state of activation. As such, they secrete a slew of pro-inflammatory cytokines, many of which are tumorigenic. So that's the sort of proposed linking between insulin resistance, weight, and increased breast cancer risk. And there's certain data points along these lines. Like if we look at metastatic breast cancer patients receiving chemotherapy, and we look at those who have insulin resistance, we see that they are at a higher risk of disease progression and that they have more inflammatory cytokines. So this is sort of a clinical data point to justify the prior theoretical rationale for this connection. And I think within this conversation, we have to really think about, well, what again is contributing to this insulin resistance? And part of that is saturated fats, but part of it is refined carbohydrate intake. And with the increase of refined carbohydrates, we jump up our insulin, but we also increase insulin growth factor 1, and that's also a result of increased saturated fat intake. So this whole kind of Western dietary pattern really alters the hormones involved with glucose control. And insulin and insulin growth factor 1 are very important in breast cancer. Many breast tumors express not only estrogen receptors, but also insulin growth factor 1 receptors. So in this study that was taken out of that larger study I presented a bit ago, the WELL study, 265 postmenopausal breast cancer survivors were followed, and their carbohydrate intake was followed specifically. And what they found was the women who kept their carbohydrate the same or increased their intake had a doubled risk of recurrence, which is problematic. Interestingly, in those women who they went back, looked at their tumor specimens, in the women whose tumors did not express insulin growth factor 1 receptors, the dietary carbohydrate intake had no impact on the risk of recurrence. But in the women with estrogen receptor EGF1 receptor positive tumors, so those tumors express the insulin growth factor 1 receptor and they increased their carbohydrate intake or kept it the same, their risk of recurrence was increased more than 5-fold, 400%. Now, we don't know which of our patients have tumors that express insulin growth factor 1 because it's not routinely reported out on path reports, so I just assume everybody's tumor expresses IGF-1, and therefore carbohydrate intake becomes an important discussion point with patients. And within that carbohydrate intake, I think it's the lowest hanging fruit, so to speak, in this regard is sucrose. This was a study, couple recent studies that found that sugar intake is increased with the risk of cancer, mainly breast cancer, and it's especially sucrose or refined sugar that drives that increased risk of breast cancer. And a lot of the other sugars that are naturally in fruits, for example, are not associated with increased breast cancer risk. The mechanisms are multiple. It's not just about changing insulin levels. It's the fact that sucrose is oxidative, increases oxidative stress, which in turn generates advanced glycation end products. And advanced glycation end products are themselves associated with an increased risk of breast cancer. We know that a diet that's high in sucrose increases inflammation in the body. There's various inflammatory cytokines that increase risk. And of course, there's the link with insulin resistance. So I think sucrose should be a dietary target for sure. And just another clinical data point, this is among women with stages 1 through 3 breast cancer. And again, they found that the women who had the highest glycemic load diets had the highest risk of both breast cancer specific mortality as well as all-cause mortality. So yet another rationale, if you will, for targeting sugar. Now, related to this we've talked a little bit about some of the components on a macronutrient perspective in terms of diet and breast cancer risk. What about timing and food timing? And what about overall caloric intake? So now we're kind of verging into just the amount of calories. And there's some interesting data points. I'm going to go through this fairly quickly, but you can kind of ignore the mice columns on all of these, just focus on the humans. If we look at a starvation diet, and we're looking at specifically IGF-1, insulin, and glucose, a starvation diet is perfect. But of course, most patients are not going to want to go on a starvation diet. So what about if we just calorically restrict the diet? We see a trend in decreased insulin growth factor 1, insulin, and glucose, depending on the degree of protein and carbohydrate restriction in each. So that's moving us in the right direction. If we just take out the protein, which should therefore drive insulin growth factor 1 down, but we don't reduce overall calories, what happens? We see that we get, in fact, a reduction in insulin growth factor 1, but the effect on insulin is actually not very favorable, nor is it favorable on glucose, because most people, when they take protein out, they tend to increase their carbohydrate load. What about if we take protein down and we lower calories? Then we start to see more favorable trends across the board. What about a ketogenic diet? So we reduce glucose significantly. Protein usually is a little bit reduced, but we're not so much necessarily, but we don't change calories. We see that there's no effect on insulin growth factor 1, maybe a decrease in insulin and glucose. So not the best. If we reduce the calories on a ketogenic diet, then we start to see decreases in insulin, glucose, and insulin growth factor 1. So what's the common denominator across all of these successful diets? It's a lower caloric intake. So in addition to talking to patients about eating more plants, eating more fiber, reducing red meat intake, reducing sucrose intake, we need to talk to them about reducing overall caloric intake as a breast cancer mitigation strategy. And caloric restriction is well known as a way to downregulate two very important pathways in breast cancer. One is the mTOR pathway. So this is initiated with the binding or the stimulation of the insulin receptor, or the insulin growth factor 1 receptor, and then through PI3K, AKT, mTOR, we get increased proliferation and decreased apoptosis. Furthermore, when insulin growth factor 1 receptor are active, we get this RAS, RAF, MEK, ERK pathway, which does the same thing. So when we calorically restrict, we downregulate the ligands for insulin and insulin growth factor 1 receptors, thereby downregulating these proliferation pathways. there's been some interesting work by Catherine Marinac and colleagues looking at, well, caloric restriction is kind of like dieting, and that's challenging. But what about if we just reduce the caloric intake by expanding our overnight fast? So we fast for at least 13 hours, and what we see is that in fact we get a decrease in hemoglobin A1C, we get a decrease in glucose concentrations, and this is going to in turn improve glucose control, ultimately reducing the need for insulin. In a further study, overnight fasting for at least 13 hours is important. When women don't fast for 13 hours overnight, there are a 21% increased risk from dying from their breast cancer, because in addition to these glucose modifying effects, fasting is also associated with decreased inflammation. So this is really important. This is also most impactful when dinner is light and our midday meal is the biggest meal. But a target clearly is caloric restriction. I think a really great place to start is a 13-hour at least overnight fast. Past 16 hours doesn't appear to give additional benefits. So 13 to 16 hours I think is the magic window for overnight fasting. And I just want to finish up by talking about some specific food groups or food acquired phytonutrients that are indicated in a breast cancer risk reduction protocol. So lycopene, which we know is found in lots of vegetables, but especially tomatoes, is associated with a reduced risk of estrogen receptor negative breast cancer. That's a particularly lethal type of breast cancer. Glucosinolates in cruciferous vegetables are associated with a reduced risk of breast cancer. In China, in fact, there was a significant risk reduction seen. Overall, meta-analysis see about a 15% reduced risk of breast cancer. Legumes are not bad. In fact, they're quite good. A meta-analysis published in 2020 found that the highest intake of soy was associated with a 12% reduced risk of breast cancer compared to the lowest intake. And there was a very important study published in JAMA in 2009 which merged data from 3 different prospective trials. And in this trial they found that soy, looking at it through the lens of either soy protein or soy isoflavones. These were not soy protein supplements or soy isoflavone supplements. These were dietary studies, so looking at soy intake, but just assessing the intake based on protein or isoflavone. And in all cases, all of these were associated with about a 24 to 36% or 34% reduced risk of breast cancer mortality and recurrence. If we look at a prospective study of women who've already been diagnosed, they've already been treated with chemo, let's say, or surgery, radiation, etc. Now they're on their anti-estrogen endocrine therapy. The risk of recurrence in these postmenopausal women is the lowest in those who are consuming the most soy. So it is impactful across the continuum of breast cancer. And we see this in that pooled trial as well, where consumption of at least 10 milligrams of soy isoflavones, which is about the equivalent, by the way, of a quarter cup of tofu or a half a glass of soy milk, is associated with about a 17% reduction in breast cancer specific mortality and 25% reduction in disease recurrence risk. This is true whether women are on tamoxifen, whether they have estrogen receptor negative or estrogen receptor positive breast cancer. Green tea consumption is also inversely associated with breast cancer risk. About 5 teacup size of green tea will give about 11% reduction in breast cancer risk and about a 44% reduction in early stage breast cancer recurrence with that 5 cups of green tea a day. And this is seen here where you're looking at another study, kind of 8 teacups versus 2 teacups of green tea. And in early stage, you see there's a significant reduction in recurrence risk, and that was not seen in the later stages. This study looked at about a 5 teacup size daily serving of green tea, and again, you can see especially in stage 1, there's a significant reduction in recurrence risk. So green tea as a beverage certainly appears to be associated with reduced breast cancer risk. Lots of mechanisms that underlie this association that are well developed. And I want to just mention alcohol on the other side of things. This is probably the one dietary recommendation that women get when they leave their oncology office, and it is an important recommendation, but compared to everything else I've talked about, this is not ultimately the most impactful unless somebody's a heavy drinker. So if somebody's drinking 2 to 5 drinks every day, they're at about a 40% increased relative risk of breast cancer. However, if they drink 1 drink or less a day, they have a modest 6% increased risk of breast cancer. That's marginally clinically significant, and that is especially and perhaps only true in postmenopausal women at diagnosis. Women who are premenopausal at diagnosis do not appear to have are not as sensitive to the impact of alcohol. And there's some interesting studies that have shown that even if women drink a drink a day, let's say, but they eat a lot of vegetables, and specifically looking at the fiber intake from vegetables, then they can mitigate the risk from alcohol. And 6 grams of fiber is all it takes, and that's not hard to get in my opinion. 1 artichoke, half a cup of green peas, a cup of cooked collard greens, a stalk of broccoli, all those things each would provide more than 6 grams of fiber, enough to sort of zero out 1 drink a day. So I'm bringing this up just for those patients who do drink 1 drink and don't or can't stop. There's another angle to this, which is folate. Folate appears to be also protective against the carcinogenic effects of alcohol to some extent. In this study, they used a multivitamin, but a multivitamin with folate, specifically looking at the folic acid component, did negate or attenuate increased risk of breast cancer associated with alcohol drinking. Now, speaking of folate, folate supplementation, I know we're talking about diet, but I do just want to mention that there's a lot of confusion around B vitamins and breast cancer risk, so I just want to briefly talk about some of this. In breast cancer BRCA1 positive, so the genetic mutation BRCA1 positive women who had any use of folic acid supplementation, they actually had a 55% decreased risk of breast cancer compared to BRCA1 women who never used a folic acid supplement. And conversely, in premenopausal women, the highest intake of B12 actually was associated with an increased risk of breast cancer. So B12 and folate don't play the same from a carcinogenic perspective. And this has also been shown in diet studies as well. If we look at the highest dietary intake compared with the lowest dietary intake, folate, a diet that's high in folate has about a 7% lower risk of breast cancer compared to the lowest intake. There is a U-shaped curve so that when the dietary folate increases more than 550 micrograms a day, there's really no additional breast cancer risk reduction seen. And B6 is also associated with a lower risk. B2 is associated with a lower risk. However, again, B12 doesn't have that same association. So B12 appears to be a little bit more problematic, we'll say. So I know that was fast, but I did just want to give you an overview from a database perspective of some of the dietary strategies that can be used to reduce breast cancer risk. And remember, we're talking about a reduction in relative risk. We're not getting that risk down to 0. Diet is not enough on its own. It's necessary but not sufficient to reduce breast cancer risk significantly. We have to talk to our patients about exercise and stress management, and for some, dietary supplementation. So there's a whole kind of integrative approach that needs to be considered, but the diet component is obviously very important. And I think using an evidence-based perspective, practitioners can really guide patients to making very reasonable, very sustainable, and yet impactful strategies. So with that, I thank you, and I hope you're having a wonderful conference.
At the outset, I'd like to thank Dr. Shagufta and the Pakistan Association of Lifestyle Medicine for inviting me to talk about exercise prescription. As we all know, exercise is one of the 6 pillars of lifestyle medicine, and it's important because it appears to improve executive functioning in individuals, and this is very helpful when we are trying behavioral change. We are trying to influence the patient to stick with the program, to change their lifestyle, and so on. So let me begin by sharing my screen. So let me start by differentiating between physical exercise and physical activity. Activity is defined as any movement of the body done using the skeletal muscle contraction that causes energy expenditure to be increased beyond baseline. So anything like walking around, cleaning the house, gardening, laundry, and so on. Whereas physical exercise is defined as purposeful physical activity that is organized or structured, planned, and recurring, and is done with the intent of improving or maintaining one or more components of one's health and fitness. And physical fitness is the outcome of regular physical exercise, which helps a person, improves a person's ability to perform activities of daily living, respond to emergencies, and enjoy life's recreational activities. Now, we know that poor respiratory function, as measured by the maximum capacity on a treadmill, is one of the highest attributable factors for all-cause mortality, ranging from 16% in men to 17% in women, as compared to the other causes or the other health behaviors like smoking, hypertension, high cholesterol, diabetes, obesity, which have a lower attributable fraction. So poor cardiorespiratory fitness, which is the result of inactivity or sedentary behavior, can be changed and should be changed in order to reduce all-cause mortality. And this is done by introducing fitness and encouraging individuals to remain not just physically fit, but also physically active. A large meta-analysis of over 305 RCTs with over 33,000 subjects found that in comparison with medication, exercise is better than medication in post-stroke treatment, equivalent to medication as secondary prevention of coronary vascular disease, while medication is superior to exercise in the treatment of heart failure. However, it needs to be remembered that exercise has a better side effect profile when compared to medication and is best used in combination with medication. The 2018 Physical Activity Guidelines Advisory Committee scientific report stated that a single bout of moderate to high intensity exercise can reduce blood pressure, improve insulin sensitivity, improve sleep, both the quality of sleep, the amount of time that is spent in deep sleep, the reduction in the amount of time lying awake in bed, and so on, reduction in anxiety levels, improvement in cognition, which I already mentioned, particularly on the day that the exercise is performed, and an improved sense of well-being. It's prudent here to also mention that exercise influences immunity, especially at a time like this when we are still in the middle of a pandemic. Exercise seems to help to boost immunity and mitigate the deleterious effects of inactivity and the stress of social isolation on our immune systems. It is imperative that we strive to maintain the recommended exercise levels during COVID-19 pandemic. The Physical Activity Guidelines by WHO, CDC, ACSM, and Fit India recommend 150 to 300 minutes of moderate to vigorous intensity cardiorespiratory physical activity per week and 2 sessions per week of strength training. Now, moderate intensity physical activity stimulates cellular immunity, while prolonged or high intensity practices, especially without appropriate rest, can actually trigger decreased cellular immunity, resulting in an increased propensity for infectious disease. And this cutoff point appears to be about over 90 minutes of moderate to high intensity physical activity. And we know that it is the regularity, the intensity, duration, and the type of effort that is applied that influences the immunity levels and how much exercise, and influences how much exercise affects immunity. So more is not necessarily better. Exceeding the recommended physical activity levels during this time is not recommended, as there is some evidence that excessive exercise might actually impair immunity levels. So it is a U-shaped curve where the propensity for, let's say, upper respiratory infection seems to decrease up to a point beyond which excessive exercise can actually increase the propensity for infections as a result of lowering immunity levels. The general prescription for exercise is about 150 minutes per week of moderate intensity exercise and 2 days a week of strength training. Before the exercise prescription, or simultaneous with the exercise prescription, we have the 4 A's of prescription for lifestyle medicine, where we first assess the patient, not only a physical fitness assessment and assess which patient needs to go in for further assessment and, let's say a treadmill test or a stress test. We also need to assess their belief system, their understanding of fitness, how much they believe that exercise can help them, and so on. We need to advise them, give them advice regarding the benefits of exercise. We may need to provide them with some information about documentaries they can watch or reading material that they can actually go through. We need to agree, or it is a collaborative effort with the patient or the individual, set goals that are that actually satisfy their requirements and can actually help them progress in a way that is self-motivating for the individual. So the goals need to be in sync with their capacity. We need to assist them with the process. So this may mean troubleshoot. They may have certain concerns about exercise. They may have certain concerns about their ability to stay on with the exercise. So troubleshooting and assisting is important. Finding the right trainer and the right program, exercise program, can also help them to get on track. And finally, we may need to arrange to actually make the connection with the fitness professional. We may ourselves be collaborating with fitness professionals or having them in our own practice, where lifestyle medicine is a collaborative practice. So all of these things need to fall into place in order to help the person to not just start an exercise program, but we also need to schedule follow-up for the patient and for the individual, so that we can be collaborating with them on a long-term basis. So the screening protocol for exercise, before exercise rather, should not actually prevent people from starting exercise programs. So if these screening protocols are extremely stringent, it may even prevent people from starting exercise programs. And as we can see from this algorithm, screening is not really required for every individual. It is required for those people with known cardiac disease or metabolic disease, and especially those who are symptomatic. It's also required for those who have not been exercising regularly and who may have some signs or symptoms of cardiovascular disease or any other metabolic disease. Obviously, when the person starts to become symptomatic, the exercise needs to be discontinued. So while the pre-participation health screening is important, but it's not recommended across the board, and what is recommended is to start at a much lower intensity and gradually progress in a way that the person is also comfortable, and it helps with the acclimatization to exercise and also with the persistence of the exercise routine. When we prescribe, we follow what is called as the FIT principle, which takes into account the frequency of exercise, intensity of exercise, type of exercise, and timing or duration of exercise. Now, the components of physical fitness can be divided into cardiorespiratory fitness, which is aerobic, occasionally anaerobic, muscle strength, flexibility, and body composition, which is nothing but the body composition, which is nothing but the proportion of fat to muscle mass in the body. So when we look at frequency of exercise, we could prescribe about 5 days a week, 30 minutes per day, 5 days a week, or shorter durations if they imply that they could actually work out perhaps 6 days a week. If it is a high intensity workout, the workouts need to be kept, frequency needs to be kept to a maximum of 3 times a week. Strength training at least twice a week. It can be increased to 4 times a week if the duration is shorter and we can address only certain body parts if it's spread out to four times a week. Flexibility can be recommended every day, perhaps a short stretch of even about 10 minutes. So how do we determine intensity of exercise? This depends entirely on the fitness levels of the individual. There are several ways of assessing intensity and recommending intensity levels, the easiest of which is the talk test, or assessed on the Bogue scale to assess this fitness, where on a scale of 1 to 10, 1 would be complete inactivity, where the person is extremely comfortable and can talk, can carry on a conversation with the person next to them. And 5 is about moderate intensity activity, where you're just walking around. You can still carry on a conversation with the person next to you. As you increase in intensity to 6 or 60%, then you can still talk, perhaps say a couple of sentences, but not more than that. As you get higher in your intensity level, at a level of 7 or 70%, you can talk, but perhaps not more than a couple of words. 8 or 80% and higher, the individual may not be able to say maybe just a word or two. And when they move beyond 8, they're not able to talk at all. They're completely breathless and the intensity is extremely high. So this is an easy way of assessing and explaining to the patient how to assess their level of intensity. We could also assess intensity by other methods like the heart rate max, where the maximum heart rate is calculated as a formula 220 minus age, and the percentage of that maximum heart rate, anywhere between 50 to 90%, can be recommended, again depending on the fitness levels. The Carbonate formula is a little more sensitive, and it uses what is called as the heart rate reserve, where heart rate reserve is nothing but your maximum heart rate, which is that maximum heart rate that can be achieved, minus your heart rate reserve. So the 220 minus age, which is the maximum heart rate, minus the resting heart rate. So if your resting heart rate is, let's say, 80, maximum heart rate minus resting heart rate would give you what is called as the heart rate reserve. And the percentage of this heart rate reserve, let's say 70% of the heart rate reserve plus the resting heart rate, will give you the actual heart rate that the individual needs to be working at. We also use another parameter called the MET, or the Metabolic Equivalent. Now this MET value is usually indicated in most exercise machines, and it goes up or down, increases or decreases depending on the intensity that the individual is working at. One MET is approximately 3.5 ml of oxygen per kg per minute. And the more the MET, the higher the MET, the higher the intensity. So anywhere below 3 METs would be very light, 3 to 5 would be about moderate, and over 5 would be a high level of intensity. Another evaluating parameter that we look at is what is called as a PI, or Personal Activity Intelligence. PI gives you an idea of how active you need to be to reduce coronary vascular disease. PI takes into account your gender, your resting heart rate increase, and your cumulated heart rate over 7 days. It runs through an algorithm based on the Hunt study, and a PI score reduces the incidence of coronary vascular disease depending on the number of points that you are able to accumulate during the course of the week. So more than 5, approximately 50, a reduction in 17% CVD has been found. When you accumulate 100.5 points or more, there is a reduction of about 28%. So the authors of this study indicated that 5 points are earned every time your heart rate increases. The higher the heart rate, the faster you earn the 5 points. And those who achieve 105 points per week over time live an average of 8 years longer than others. Pi reflects the intensity of your activity by measuring increases in heart rate. It can be measured on most common fitness trackers, smartwatches, and so on, and it needs to be higher, 100 or higher, to improve coronary vascular fitness and increase longevity. Now, type of exercise, when you recommend the type of exercise, be specific about the type of exercise and help the patient understand which aspect or pillar of fitness it improves. Some types of exercise, like for instance, strength training exercises that are done at a higher speed with no rest between sets, can actually improve more than one pillar of fitness. It can improve both cardiorespiratory fitness and strength. So an exercise prescription should actually span the various stages of their progress. So for instance, the initial stage, which usually lasts about 1 to 4 weeks, the prescription could recommend a frequency of 3 times a week. Intensity needs to be slightly low to acclimatize and prevent undue muscle soreness. So it can be about 40 to 50%, and a duration of not more than about 15 to 20 minutes so that the person doesn't get overwhelmed. Once they get used to the initial phase, once they get acclimatized, you move into what is called as the improvement stage, which can last anywhere between 5 to 24 weeks. And the frequency of can be increased to about 3 to 5 times a week. Intensity can be increased from 50 to almost 80%, depending on the improvement of the individual, and the duration of about 25 to 40 minutes. Once they move into maintenance phase, which is over 24 weeks, frequency can average anywhere between 3 to 5 times a week, again, depending on the intensity that they are working at, anywhere between 60 to 80%. The higher the intensity, the lower the frequency, and the lower the duration. Duration anywhere from 15 to 20 minutes, again, or it can go up to more than 20 minutes, depending on the intensity that you are recommending. It's designed to maintain or continue to improve fitness. Now, all of this obviously depends on the individual. Some people may progress from one stage to the other very quickly, while others may remain in the initial stage, continuing to acclimatize for even more than 4 weeks. So, which is why the follow-up of the patient is absolutely essential. What if you cannot exercise? Those who have not exercised at all or are unable to exercise and have not been exercising, if they perform little or no moderate to vigorous physical activity, no matter how much time they spend in sedentary behavior, we can reduce the health risk by gradually adding some or more moderate intensity activity. If there is inadequate exercise where the recommendations are not being met, even small increases in moderate intensity physical activity provide health benefits. There is no threshold that must be exceeded before benefits begin to occur. Obviously, greater benefits can be achieved by reducing sedentary behavior, increasing moderate intensity activity, or a combination of both. Type of exercises vary. Exercise can be done with home equipment or exercise machines. So the role of muscle is often underappreciated. Muscle is also very important for the management of diabetes, as it appears to improve insulin sensitivity. So it needs to be recommended in the pre-diabetic and the diabetic stage. What we do is try and improve muscle hypertrophy, which in other words is considered as building muscle, which is done with what is called as the overload principle. And when we implement the overload principle, which I will explain, hypertrophy of the muscle cells happens with the overload principle. There is an increase in the motor unit recruitment. Muscle changes with alteration in tension or from the damage to the muscle cells, which happens when we apply this overload principle. Challenging the muscle to work beyond its capacity is what is required for the muscle cells to hypertrophy. This repair and hypertrophy happens during the rest phase and not during the actual exercise phase. By manipulating the intensity of exercise, volume or the number of sets and reps, and the exercise selection, we can actually increase the muscle mass by muscle hypertrophy. So for instance, when you do squats, which is considered the king of all exercises, which addresses the large muscles of the lower limb, like the quadriceps, the glutes, the hamstrings, and the core, we first of all need to correct the form of the exercise, because improper form can actually lead to injury. So instructions like hinging at the hip joint, keep the knees over the toes, sink the hip down to the level of the knees, keep upper body as erect as possible. All of these instructions need to be repeated. And obviously this is done by the fitness professional. So a well-qualified fitness professional is absolutely mandatory. We can add, by adding weight to a squat, either by using barbells across the shoulders or holding onto dumbbells, one can increase intensity and therefore challenge the muscle further and encourage hypertrophy, thereby building muscle. Now, in order to assess this intensity, we can use what is called as the 1 rep max. And I must mention here that this assessment of 1 rep max is not done for beginners. It's usually done for a more advanced exerciser. This is the maximum weight that you can lift for a particular exercise, and this varies from exercise to exercise. 1 rep, so when you can lift, for example, 100 kilo weight for a deadlift, 70% of your 1 rep max, with 70% of your 1 rep max, you would be able to perform approximately 12 repetitions of that exercise before the muscle goes into failure. This is an average and an approximate evaluation. A range of anywhere between 70 to 80 to 90% of that 1 rep max using different number of sets and reps will challenge muscle hypertrophy. As I said, this is not done for beginners. So 1 rep max for a deadlift, for instance, could be about 100 kilos or 50 kilos, depending on your strength. And then we evaluate the amount of the weight that needs to be used to perform 12 repetitions. So just to mention, this, without assessing 1 rep max, we can actually recommend that the individual starts with a weight that one can perform about 12 repetitions with. So that would be an average of 70% of the 1 rep max. So we can work backwards. And when we say 12 repetitions, the individual ideally needs to start tiring. The muscle needs to start tiring by about 10th or 11th repetitions, so that by the time they reach the 12th repetition, muscle is completely gone into failure and they're not able to do any more repetitions without resting. So that's where the rest comes in. So one usually performs about 3 to 4 sets with about 30 to 40 seconds of rest in between. Now, flexibility helps to increase muscle length. It's not actually length, it is actually elasticity of the muscle, because the muscle essentially cannot increase in length as it is attached at both ends. So it's muscle elasticity and range of motion. Flexibility decreases with age and with disuse. Decreased flexibility can lead to aches and pains and also lead to muscle imbalances. Falls and injuries can be prevented with a combination of strength training and an improved flexibility and balance training. So individual muscles or groups of muscles need to be stretched using different stretch protocols and different stretches for each of these muscles. Balance training can also be included if there is a trainer who is competent in advising balance training, because balance training, especially for older people, it improves the ability to withstand postural sway or destabilizing stimuli. And it's been found in a meta-analysis of RCTs that with balance training, 37% decrease in injury from falls, a 30% decrease in injuries resulting in medical care, 43% decrease in severe falls, and 61% decrease in falls resulting in fractures has been achieved. So time of exercise, again, depending upon how much they are able to set aside for their exercise routine, one can recommend 45 minutes a day of cardio, 30 minutes a day of cardio, and include strength training maybe twice a week. So approximately 45 minutes a day, 5 to 6 days a week is what can be recommended. And obviously the days that one is doing strength training, one needs to either decrease the amount or completely eliminate the amount of cardio that is done. So each individual is different, and that's where your assist and agree and arrange all those different principles need to be followed, where long conversations need to happen with the person. So a sample prescription for cardio can look something like this: 20 minutes per day of walking at an intensity of 60 to 80%, 5 days a week. Advanced can be HIIT for about 20 minutes, and a longer duration of lower intensity cardio, 30 minutes. This is a list of HIIT that can be done, where you have a 40-second challenge of performing the exercise followed by a 20-second recovery, and the entire sequence is repeated once or twice. Strength training sample exercise prescription, if they are able to do 4 days a week, Mondays and Thursdays of upper body, Tuesdays and Fridays of lower body at 60 to 70% intensity, which is about 12 repetitions per set, 3 sets per exercise, 6 to 8 exercises per day, about 30 to 40 seconds rest between sets. And this may come to about 30 to 40 minutes per week. Flexibility sample prescription, either sun salutation, Surya Namaskar, yoga, which is very popular in India, and simple static stretches for all the muscles. So a sample prescription would look something like this: cardio 5 days a week at 60 to 80% intensity, walking or running 20 to 40 minutes, strength training 60 to 70% intensity, addressing the whole body 20 to 30 minutes, flexibility 6 days a week, total body stretches 10 minutes. Now, it is imperative that I mention that other aspects of health behavior do affect health, weight, and well-being. So attention needs to be paid to restorative sleep, proper management of stress, adequate nutrition, management of addictions, and nurturing of authentic social connections. So as the ancient Greek philosopher Plato said, lack of activity destroys the good condition of every human being, while movement and methodical physical exercise saves and preserves it. Thank you very much for a patient hearing. I hope
Assalamu alaikum. I am Azhar from 4th year MBBS Islamic International Medical College, and I am here to perform some healthy lifestyle activities with you. For that, I request all of you to please stand up from your seats and do some stretching with us. We have Syed Ahmed Shafiq Bukhari from 4th year MBBS to guide you. Kindly stand up from your seats, please. Please, starting from abducting your shoulders above your head, interlocking your fingers, reach forward, bending from your middle back, stretch your hands forward at your shoulder level. You will feel the stretch between your shoulder blades. Now relax, relaxing your shoulders. Move your left ear towards your left shoulder using your left arm. Stretch as far as you feel comfortable. Now try to balance your body with this balancing exercise. Standing with your weight on your one leg, raising your other leg on your side. Let's see how many of you can actually balance themselves. Thank you so much. Please have your seat. Exercise in medicine is a global health initiative. Do you know, a single bout of moderate to vigorous exercise can decrease blood pressure and increase insulin sensitivity. Obese but physically active individuals have slightly fewer years of life lost than normal weight but active individuals. We can burn about 350 calories per day with just NEAT, non-exercise activity thermogenesis. Breaking hours sitting with light to moderate walk every 20 minutes decrease blood glucose and insulin level in obese. Healthy exercise daily is an important pillar of lifestyle medicine. Thank you.
Now, I would like to invite the last keynote speaker of this session, Professor Dr. Anis Ahmed, Vice Chancellor, Rifai International University. Sir, I would like to request you to please come on the stage and enlighten us with your thoughts on the topic, role of belief in holistic immunity.
Bismillahirrahmanirrahim. Alhamdulillah wassalatu wassalamu ala khatamil anbiya. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. First of all, I must congratulate the Dean and his team, Dr. Gupta particularly, whose presence in this institution has brought a new dimension to all of us. Besides emphasis on medical treatment, we should give equal importance to non-medical aspects of improvement. And that's the Dr. Gupta's contribution to this institution. I appreciate that very much. Health and well-being are two simple words, but they include a treasure of knowledge. And if we look from an Islamic perspective, it appears that the objectives of Sharia, at least two of those, directly point out towards well-being and health. Classical thinking in jurisprudence tells us that Sharia has been designed for the protection and promotion of human life. And this promotion and protection of life includes several things. Well-being in terms of physical fitness, well-being in terms of spiritual fitness, well-being in terms of psychological fitness, and well-being in terms of their overall social fitness. These four aspects are taken care by the first objective of Sharia, which calls for a serious effort at the part of every individual to create an environment where life is promoted and life is preserved. Similarly, another foundational principle is, which the Quran calls adl, or moderation and balance. And that means whether it's a talk, whether it's a walk, whether it's a matter of doing an exercise or enjoying a dinner, in every single area there has to be a moderate approach. And when we become immoderate, when we exceed our limits, then we are causing an imbalance. Therefore, these two very foundational principles of hifz an-nafs and adl, which are part of objectives of Sharia, guide us towards a different vision, different approach of life. Similarly, we find that Quranic principles of not exceeding or not doing asraf, wala tusrifu, reminds us that in any situation, if we go beyond our limits, then we are going to overburden ourselves. At the same time, we find that Quran talks about its own content and tells us we have revealed this Quran which carries shifa for all of you. What's the meaning of shifa here? Is it a matter of just some medical prescription in the Quran, or it's a matter of the overall improvement, overall enhancement of quality of life? Quality of life cannot improve unless all four aspects, physical, spiritual, mental, dealing with our dietary regulations, dealing with our everyday life, all these aspects are considered together. Similarly, the Quran also refers to food and aspects that bring more strength to our activities. The Quran talks about honeybee and tells us that Allah subhanahu inspired honeybee to go around and get juice and manufacture out of it a drink which carries shifa for people. And that means Islamic approach to well-being is not confined to one single aspect. All those aspects are put together. At the same time, we find that the Quran itself has a soothing effect. A large portion of human problems arise out of stress. And listening to the Quran or reciting the Quran both bring a consolation, an environment of peace, and clinical studies done by a very dear friend of mine, Dr. Ahmad Al-Qadi. He was a cardiac surgeon in Florida and had a clinic of his own, and he conducted a series of clinical experiments on Muslims and non-Muslims who listened to Quran recitation, and then data was collected, how it works on reducing tension. In Pakistan also, some people have done that, and I remember I was approached by someone who came to me, and then we had a discussion with him. He went around to various places in Pakistan, hospitals, prisons, villages, and everywhere tried to play recording of Surah Ar-Rahman and then collect responses of the people. He was not using any scientific equipment, but anyhow, the data that he collected and shared with me indicated that whoever heard Surah Ar-Rahman, a number of ailments were influenced by that, and a positive response was coming out physically, spiritually, and emotionally. That means what we call spirituality, or in our terms, what we call deen or the Quran, that has a definite impact on human behavior. As a social scientist, I know that a number of human problems are not confined to one single area of their physical existence, but psychosomatic aspects are extremely foundational. And therefore, when we look on the human being as a totality and not just as a microcosm, then we enter the area of holistic health care. The biggest problem that we face today is we have moved from a holistic approach to a micro research approach. In every single discipline, there is micro research, and we concentrate on small aspects of human life and forget the total human being. Look into studies based on psychological data. Everything is reduced to psychosis. Look into studies taken from sociological viewpoint. Everything boils down to social constructs. Look at studies done from economic viewpoint. Human being becomes only economic animal. And same applies in terms of anthropology, where when we look on human being with a camera, with analysis of how human beings behave, the whole human personality becomes a skeleton. Therefore, modern social sciences as well as applied sciences have developed an approach of micro understanding which loses macro understanding. When we talk about holistic healthcare, it means we consider human being as a totality, and no human being can exist without a social involvement, without emotional involvement, without cognitive involvement. This cognitive, emotional, and spiritual involvement brings that balance in life, which makes life more meaningful, more pleasant, more desirable. Therefore, I believe that this sort of discussion we are having this morning should not be confined to periodic conferences, but to regular organized activity, and at the same time a regular content in our syllabi. Our course structure should be reconsidered in view of how we can make a different course structure where the emphasis on exercise, emphasis on use of proper diet, and at the same time proper understanding of man. Human being not just as a physical being, not just economic being, not just political being, not just a bundle of desires and psychosis, but human being who has a totality. When we go for that totality, we will be able to make a contribution in the world of knowledge and at the same time provide our students a different approach than what they have been hearing for centuries due to our intellectual colonization by the West. We think and act and talk in terms of what we call best practices of the West. And that has to come to an end one day. If we want to move forward, we have to liberate ourselves from this shackle of colonization intellectually and come up with our own approach of holistic life, which is provided by the Quran and Sunnah. The prophetic example and the Quranic messages indicate that we have to develop an approach which is balanced, an approach where it is not me who is everything. Indeed, the Quran says, in honey there is shifa, but there cannot be any shifa without the shafi. Unless the one who gives shifa, it cannot operate. And that means conviction, that means faith, that means confidence, that means reaching a stage of life where we have no tensions, but we transfer all tensions to our Creator. When I say Allah willing, then consciously and psychologically I transfer all my burden to Allah subhanahu wa ta'ala. I leave it to Him. Sometimes things happen not very pleasant, but Allah knows in that unpleasantness what may be hidden as a benefit for the individual. Therefore, the more we develop faith, dependence on Allah subhanahu wa ta'ala, the more we'll be able to get rid of tensions and enjoy a better life. I thank the organizers for giving me these few minutes to share with you my ideas. And again, I congratulate the faculty, Dr. Shugufta and her department for organizing this very important event. I would like to see that we have every year this activity programmed as an institutional activity of the university. May Allah bless you all. Jazakallah khair.
Jazakallah, sir, for such an amazing talk. Now, I would like to request Lieutenant General Retired Professor Dr. Azhar Rashid, Hilal-e-Imtiaz Military, to conclude this session. Sir, please.
Bismillah ar-Rahman ar-Rahim. I'm sure all of you who are sitting here they must have benefited from all the talks. We heard Dr. Liz Ashula, then Dr. Sheila Nambiar, and finally our very respected and worthy Vice Chancellor. They were all three different aspects. But all those aspects, they were having an effect on the Homo sapien. If you look at the end, we are all quarks, nothing, nothingness. We are all waves. And before that, what combines together, it becomes some chemicals. Then the combination of these chemicals takes different forms. Some became human beings, some became plants. So it is, as our worthy Vice Chancellor said, the word holistic. In that sense, everything is the same and they interact. So on the human beings, when we take diet, it's the combination of the chemicals. Similarly, during exercise, certain chemicals are released which affect us. And another word which was used was adal, which means moderation and balance. And that's what Islam tells us, how to use these chemicals and create a balance, whether it is spiritual, mental, physical, or through the diet. I think that's an art we have to learn. I will end it by saying that about the religion, why spiritual effect? I think the faith, what faith creates is the concept of Tawheed, is the unity. It creates the unity of mind. There is no split. And the chemicals which are produced are different. And just imagine, if you don't have faith, what happens? The mind is split. And when the mind is split, what enters? Doubt and fear. And that destroys you. So understand why faith is important, why diet is important, and why exercise is important. And all these aspects, the word is adal, the balance, the moderation. There lies the success. Thank you very much. And I think it was a great session. Doctors in trouble. So Dr. Shagufta Feroz, I'll congratulate her. Her concept is live without medication. So all my deans and my head of the departments, please start thinking what to do with Dr. Shagufta Feroz. Thank you very much.
Thank you, sir. Now I would like to invite Dr. Shagufta Feroz, Director, Rifa Institute of Lifestyle Medicine, to distribute the certificate of appreciation to chair and co-chairperson of this session. I would like to request Professor Dr. Anis Ahmed, Vice Chancellor, Rifa International University, to receive his certificate of appreciation as a keynote speaker from Dr. Shagufta Feroz. Sir, please. Thank you, sir. Now, I would like to request Lieutenant General Retired Professor Dr. Azhar Rashid to kindly receive his certificate of appreciation from Dr. Shagufta Feroz. Thank you, sir, and thank you, Dr. Shagufta Feroz. Ma'am. I again request Professor Dr. Anis Ahmed, Vice Chancellor, Rifa International University, to receive his certificate of appreciation as a keynote speaker from Dr. Shagufta Feroz. Thank you, sir, and thank you, Dr. Shagufta Feroz. Now, at the end of this session, I would like to say thank you for your patience listening. Now, there is a short tea break session of 10 to 15 minutes. You are requested to please come back and be seated at sharp 10:45 a.m. for the formal inaugural session. Thank you.